The purpose of the Global CFO Council is to provide an educational and networking forum for senior financial executives in order to share best practices, discuss current financial issues, and to learn about current topics related to the performance of their jobs. Membership is open to senior financial executives including CFOs, financial VPs, and treasurers. We hope that you'll become a member of the Global CFO Council today. To join, please visit the membership tab at globalcfocouncil.com.
Sheila and Jonathan, super excited to have you both here. I mentioned before you started that my shtick is I like to find information on the internet about you before you start speaking and reveal it to everyone and share pictures if I can find them. And I could find nothing. You are both doing an exceptionally good job keeping yourself off the internet and me from finding information. So I've got nothing. It's a very boring introduction. Sheila Davis is the Director of Business Development at Beacon. And I think you live in Virginia. Jonathan Elliott's the CEO and also lives in Virginia. That's about what I got. I got nothing interesting from you both, but I know the topic is going to be very interesting. And so I'm going to mute myself. Jonathan, I'm going to yield the floor here to you so you can do some intros of the firm. And then Sheila, really looking forward to your presentation. And then I'm going to hit you up with some questions, rapid fire. Thank you very much.
Robert, thank you very much. And thank you everybody for joining us first thing in the morning on your Thursday. We are really excited to be here to address Rob's discussion about me not being on the internet. That is by design. We are a compliance services company, and in the compliance services realm, social media is not really something that people want out there. They don't want people tweeting and being out there posting too much information. And I've been doing this a long time, so I do try to keep my profile as low as possible. I am the CEO of Beacon HCI, which is a subsidiary of Research Data Group, which is the parent company. And I'm really excited for Sheila's presentation. I'm going to give you just a brief overview of what we do. We build compliance systems that allow our clients in the healthcare space to make sure that their bills are being reviewed properly and that they are able to pay the proper amounts or go after refunds for overpayments. This allows us to do it for all companies. It's not just self-insured, but that is where we focus a lot of our energy. But we are able to take any healthcare data set, any claims data set, and do a review of it to make sure that the claims are being administered properly and paid properly, and give our clients the leverage to negotiate better terms in their healthcare plans or get money back. And that is what we have been working on for the last many years. Beacon HCI started as a family business 25 years ago. We came in and acquired it 5 years ago to scale it up and build out the nascent software program that they had. And we've done a fantastic job of that. And we are now processing thousands and thousands of claims every month. We have the ability to ingest electronic data files. We have the ability to ingest archaic PDF files, regular hospital claims and things that people usually keep in a drawer under their desk. We can take those in and we can find any errors that might be made by either the hospital or the provider and return to you a complete trail of what we found, why it was wrong, and a defensible system for either recovering money as well as an appeals process should the provider say, oh, we don't agree with that. So there's a lot of things that Sheila's going to talk about here that are more specific in terms of our process, but that is in general what we do. We've got offices all over the country. We have offices, our headquarters is in Salem, Virginia. We have a large office in Boise, Idaho. We also have office in San Francisco, which was where we were founded. And we have a total of 85 employees. So we've got quite a bit of experience and knowledge that Sheila is going to shed light on. With that, Sheila, I'll hand it over to you.
Thanks, Jonathan, and happy Thursday, everyone. Thank you for starting your early morning with us, myself, Sheila Davis, and Beacon HCI. We are happy and excited to be here with you. First, I just want to tell you about that. For more than 20 years, Beacon HCI has been dedicated to uncovering and correcting medical billing errors. It is driven by a commitment to accuracy and integrity. We harness innovative solutions to deliver exceptional service and to ensure the best outcomes for our clients. Today's topics will be the high cost of healthcare. We're going to talk about some healthcare claims statistics. We're going to talk about self-funded health plans, and some key considerations for rented network contracts. We're also going to you may hear me say this many times, it's your company's money, and you have the right to know what you're paying for. So a common concern, we all have participated in discussions about escalating healthcare costs. And the current buzzwords are, everyone listening, fraud, waste, and abuse. So yet, despite these concerns, our premiums continue to rise each year. So in 2022, the U.S. spent $4.5 trillion on healthcare, growing by 4.1% from 2021. In 2023, it rose to $4.9 trillion, and long-term, by 2032, healthcare spending is projected to reach 19.7% of our GDP. That's outstanding, right? That's way staggering, is what it is. Despite the challenges posed by the COVID-19 pandemic, these costs continue to escalate, highlighting the urgent need for effective cost containment strategies. So some insights about 5,000 claims that we reviewed some time ago. So there were random 5,000 claims. So the claims were both for provider and hospital claims. There were a total of 5,025 was the exact number. Of the 5,025 claims, 94% of the claims had errors. Let me say that one more time. One more time for those who didn't hear me. 94% of those claims had errors. And of course, 6% of those claims were clean, which means they were perfect. So prior to pay claims, we call prior to pay claims that we review prior to the TPA actually review them. We saved $10,272,451.41 on the 2,528 prior to pay claims in the sample of the 5,025. That is actually a savings of $4,063.47 per claim. We also reviewed 2,497 post-pay claims in that sample as well. But again, I want to say once more, the important thing to take away from this slide is there was a 94% error rate on the 5,025. So self-insured. So what is a self-insured health plan? So self-insured employers assume the financial risk they assume the financial risk of directly providing healthcare benefits tailored for their workforce. And as healthcare premiums rise, many are questioning the sustainability for their health plan. So your health plan is very important when trying to hire and retain the best talent. This approach also can lead to long-term savings and improve employee care. Analyzing claims pre or post payment can save 13 to 18% of your total claim savings or total claim cost. For example, if your company is spending $25 million on claims annually, cost containment could yield a 13% savings. Or if we can put it into dollars, around a $3.2 million savings, which is very significant. This is probably the place I would say, does anyone have any questions? But we'll get to those at the end. So you may say, well, what are you finding on the claims? Sheila, what is making up 13 to 18% of the error rate? Well, I'm going to talk about a few things that we've seen. There are lots of things, right? but there are a couple of things that are extremely egregious that we find quite often. Quantity errors is a big thing. So a patient may be billed for a full bottle of medication when they may have only been given 5. The overcharge can be as much as $23,000 for 500 tablets in a hospital setting, because the hospital is going to get larger quantities. You may say, is this a mistake? We like to think so. But sometimes we don't know if they're mistaken 50 for 500, or should have they actually entered in the number 5. There's a thing called hospital-acquired conditions. And a hospital-acquired condition is a condition that it happens to a patient due to an error in the hospital. It could be something that significantly causes their condition. It could be sepsis, it could be an infection. But when a hospital-acquired condition occurs, from the moment that it's diagnosed within a hospital setting to actually until discharge, those days are not supposed to be charged to the patient nor to the group. Often it happens. Actually, almost always it happens. Trauma activation is another big place where we have a lot of egregious billing. And so trauma hospitals normally get 80% of bill charges. So no matter what they put on a claim, however many dollars, because they call it a trauma, they get paid 80%. So if a patient walks in to an emergency room for an ER visit, they avoid the trauma charges and the trauma activation charges. That charge can range from $10,000 to $30,000. But if a patient is also presented to the ER and they are called as a trauma, the difference in the pricing can be from $32,000 to $100,000 to $150,000. If it's a true trauma, it needs to be called a trauma, right? Because there are certain equipment and certain doctors and certain nurses that are allocated for a trauma service. So by no means am I suggesting that it shouldn't be a trauma if it should be. But quite often we find that claims are billed as trauma when they should not have. Prior to pay or post-pay, you've heard us talk about that or heard me say that a little bit earlier. And you may say to yourself, I don't know what the difference is. So we're going to talk about that a little bit. So prior to pay means simply that the claim is reviewed prior to the payment by your TPA or your whoever self-administers your claim, your health plan, if I may speak. So the advantage of this is the savings is taken immediately. We would review the claim. We would remove anything that's ineligible or should not have been added to the claim, or any HACs or any wrong types of quantities in medication. When it goes back to the TPA with a recommendation of payment, the savings is on the top, right? On post-pay, when there's a post-pay review, the claim has been paid. Beacon would review the claim afterwards. We would say, yeah, you may have the same things on the claim that should not have been paid. We then would request the refund from the facility. And then the facility may say, well, we've been paid now. We don't want to get money back. You know, it's hard to get money back out of especially a big hospital system once they've received payment, even if they know that it was in error. So those are the big differences. So you may say that my company is self-insured, but isn't my TPA already performing this service? Well, I'm so glad you asked. So based on the analysis of the 5,000 claims we looked at, of course, the greatest savings is prior to pay. But some carrier contracts may limit your ability to review and to remove ineligible charges before a claim is paid. In those cases, companies often resort to the post-pay review. However, post-payment recovery is challenging, as I've discussed already. But a proactive approach ensures better financial control, reduced healthcare costs, and your company's bottom line. So what are you saying, Shayla? Whether it be prior to pay or post-pay, doing something is always better than doing nothing. Also understanding that it is your money and you have the right to know what you're paying for, is great to understand and know your fiduciary right. So many times your carrier is going to say, it's privileged information, we don't want to give that up. Well, the Transparency Act, there's so many governmental acts that are, or laws that have now come into play that now say your information, your claim data, the amount that you're being paid or what the claims you're paying should be very transparent. You should know these things. If you have a carrier who says that, you know, it's against your carrier contract, then if it's time to negotiate, that would be a good place to start negotiating. Say, you know, we want the ability to be able to look at our contracts or to look at our claims. We want the ability to know what we're paying for. We want the ability to know if the hospital is getting paid less than actually what we're paying, because we've actually seen that. It's your money. You are your company is the fiduciary, and as the fiduciary, ERISA says you have the right to know what you're paying for, what your claim data looks like. And I'm not even suggesting that you would want to know patient information. Claim information and patient information is totally different. The high cost of healthcare affects all of us. And one of my favorite quotes is, I think we do so much better as a country when we go step by step toward a goal. And the goal in this case should be reducing the healthcare costs. This was a quote by Lamar Alexander, former U.S. Secretary of Education. Thank you for your time. I am ready for questions.
All right, Shia, thank you for teeing that up. Jonathan, Sheila, you guys covered some great content. I have a ton of questions. I'm going to hit you rapid fire with some that I got from members before the meeting and my own questions, and then I'll pull some out from the audience here. First question I had, when the data set, how do you get the data set? How do you request this information from the carrier? And I also thought, I've been through a few carrier changes, and so how do you get it? If anybody's like, oh, I'm about to do a carrier change, how can you go back if you're still not a client? So just data set question. How do you get this data?
Great question. So, Robert, it really depends on your carrier, depends on your TPA, depends on how your claims are processed. If you're a self-insured group and you have a TPA, the claims go to your TPA, so we can get that data set from the TPA, right? Or if it's self-administered, whoever's the self-administered from the group also has access and can get that data as well. Quite often, most plans have a clearinghouse system or a computer system or a software that houses that information for them. They can get a report, whether we don't care how it can be Excel, it can be PDF, it doesn't matter, or just plain 837, and get that data to us.
Once you have the data, and not only errors, I was also thinking it would just be good benchmarking information. I was I could see a facility charge that's right for where they went, but boy, the facility charge is really high. It was not the low cost provider if I was actually looking at this data. So not an error, but just really high, not being a good consumer. And are there benchmarks if I'm looking at facility costs? Are there benchmarks if I'm looking at my pharmacy costs? If I get that data, can I benchmark? Should I benchmark? Talk to me about that.
So the truth of the matter is there are no caps on what can be charged either by a facility. Well, I'll answer that portion of it first. So a lot of times it's based upon the region, the part of the world you are, the country, the state, or the city, how rural you are, the providers, what your specialties are. The federal government does not put a cap on how much can be charged. So the charge amount may seem egregious. What is the most interesting is the amount that your carrier has agreed to pay for those charges. Okay, so that would be the information in my mind that would be the most beneficial in your data set is to see, not, you may know what they're charging, but how much is being paid. Because the difference in that is just a write-off for that facility, which ends up being a tax credit or whatever. So, and there's no caps on that. When it comes to your pharmacy, a lot of pharmacy, it is hard. It is extremely hard to assess if it's egregious, because of your carrier may have so many different, what they call PBMs or pharmacy contracts with different distributors to different industries, or Pfizer may have one contract and someone else may have another. So again, it goes back to the data will show you trends. If you watch your data, if you get your data and we assess it for you, it allows you to see, oh, we're actually paying, as a company, we're paying $200 for diabetic medicine this year. And you look at it next year, why did it go up to $300? Because as your carrier negotiates a new pharmacy contract, they may send it to you, but they may not get into weeds of how much they're increasing or decreasing based upon the contract. Also with pharmacy, it's also important to understand that there are rebates. There are rebates that on certain drugs that the manufacturer gives. And when you're looking at your pharmacy contract, it's also to understand whether those pharmacy rebates are going back to your company or are they going back to the carrier. And quite often in your carrier contract, they said they will receive your rebate. Some companies don't even know their rebates on certain pharmaceuticals.
If I can add in a couple of things about that, benchmarking is fantastic in this industry. It's also very difficult to come by. In the financial world, plan sponsor reporting for 401ks, for example, you've got plenty of indexes to compare to. It seems every day we're adding thousands of indexes. Peer groups, you can do that quite easily with publicly available information. This is all private healthcare information. So we are able to build benchmarks within data sets. Once we get a company's information and data, we are actually able to see if the same service costs different amounts within the facilities that they use in their local communities. So the benchmarks actually come directly out of that data. And then over a long enough time frame, over a year, for example, we're able to see, all right, who paid what, where, what region of the country, and is the same facility charging two different amounts? Why is it two different plan amounts? There are a lot of ways to slice and dice. What Sheila was talking about with pharmacy, there is the wonderful term AWP, average wholesale price.
Yep.
And we are able to ingest large data sets of that information. And then our software program can actually tell you, did you pay the best amount? And here is the backup data for you. There's no publicly available set, which is it's a large problem in terms of the framework of how healthcare is laid out. But we are able to ingest all of that, and we have multiple data sources for AWP. We also have a fun one as we're compiling our own database of the cost of implants used in surgeries. And that is a huge area of overbilling because we know that a facility will pay $4,500 for a instrument or a implant feature, and they will charge $45,000 for it. And those markups are not uncommon, but we're able to build those from the actual data that we see. To your question, Robert.
One follow-up. I believe I read one article, so I'm an expert, that one benchmark could be on facility cost, Medicare reimbursement rate, and trying to be within about like 200% of what the Medicare reimbursement rate. And then right after I Googled that, I read, I think that South Carolina, where I live, is wildly higher than that average. And some states can be in like, in the state you're living in, 300 could be a good percent. And I don't understand that part, why a particular state would be well above sort of the rule of thumb, 200% of Medicare? I've been meaning to ask somebody, and you're just present while I'm reading random articles from weird news sources. So any thoughts on that, Jonathan or Sheila?
I'll be happy to jump in first and then pass it to you, Sheila, for more specifics. The general is they take what they can. They get what they can because there's nobody watching. There are 5 Medicare investigators for the entire country. 5. That's not an exaggeration. So they do it until somebody says no, and it's easier to ask for forgiveness, as we all know, than it is to be proactive and stop up front. So that is the cynical truth. However, in your research, if you go ahead and take the next step and look for, can I get a Medicare pricing table anywhere? You can't. There's nothing publicly available. We are constantly trying to get them to publish something that tells you what the Medicare pricing is. So right now, a heavy spotlight's being shined in that area. We hope that spotlight doesn't go off anytime soon. We'll see. It is a very interesting thing. There are a lot of different ways to reprice things, and people are sort of throwing darts at a board and saying, is this percentage good enough? Sheila, pass it to you.
Yep, sure. So what happens a lot of times in different states, you have your carriers. States are carrier heavy normally. One state may be heavier with Cigna. The next state may be heavier with an Anthem product or your Blue Cross product. And then the next may be United Healthcare. What happens when those carriers go into a state, they start visiting providers and facilities and say, we want you to be a part of our network. And in order to be a part of our network, we're going to pay you more than Cigna was paying you, or we're going to pay you more than United Healthcare is going to pay you, or we're going to pay you for things that we should not pay you, things that we know Medicare says are not billable or payable on the claim. So that's how your commercial carriers end up paying more than the 200% that you've seen. That is the Medicare reimbursement rate, because it's about the carrier, it's about the state, and how they've negotiated the contract with the carrier, with the providers and the facilities in order to get them in their network. And then you have to remember that every carrier, Anthem is competing with Cigna, and Cigna is competing with United Healthcare, so everyone's trying to make their contract sweeter. So in other words, what are you saying, Sheila? What I'm saying simply is this: when your carrier comes to visit your employer or your HR team or your CFO and your HR team, and they tell you, we're on your side, we're on your team, please know that they're not. They are absolutely devoted to their network group. They are competing with the competitors to make their network bigger and better, and in order to do so, they will promise the world to a facility within reason.
I'm writing that down. In the presentation, you talked about there was a trauma example about did they walk into the ER or were they wheeled into the ER? And I thought, was that found out by human review, by it just being an outlier in the dollar amount, or is there some sort of technology in the background that's looking at factors, if-thens, and highlighting it like red, yellow, green for review? Talk to me a little bit about how you find something like that.
Good question, Robert. Very good question. So yes, actually yes to almost everything you said. Initially, the claims go through our system and they're highlighted either green or blue. When there is an activation code on a claim, or it can be one or many different factors, or if a claim's at a certain threshold, certain dollar amount, then that's going to cause for us to have, and nurses, we have nurses on staff, certified coders as well. It's going to cause for a nurse encoding review. The particular trauma that we're actually using an example was found by humans. So we do ingest a lot of claims electronically and they go through our system. However, when they meet certain circumstances, those claims are spit out or put aside, if you will, so that our team can review it.
The easiest threshold to talk about there is really dollar value, because a trauma activation is very rarely going to be under $10,000.
Oh, yeah.
We do manually review many claims that are under $10,000, but anything that's over 10 grand is going to get a nurse review on it. And we do have the technology, and we've been able to scale this for the first time ever, I think, with the idea that each claim is wrong. And we look at it from the point of view of what's wrong with it. So if we see conflicting codes on the front end, or we see hospital acquired condition code or a trauma activation code on a claim that only has 3 or 4 line items on it, for example, you have a trauma activation, it's going to be a lot of things that should be on that itemized statement. And if it's short of 10 individual line items, there's something wrong. So there are a lot of ways that we are able to utilize the blossoming technology, and it's not AI at this point. It will get there, hopefully, but we really have been developing this for years and years prior to AI implementation. So we've been able to take the knowledge and work of our 25 years of experience and put it into a system that is able to evaluate these claims similar to how people think of AI, meaning we've taken the brains of our good people along with federal compliance regulations and Medicare rules, and we've been able to put them into a data set that is run across every single claim very, very quickly. I hope that.
I feel like one of the past 2 presidential administrations passed an executive order about price transparency, but I don't see it. And the way you professionals are talking, you're not seeing it. Why isn't there more price transparency? Why is it impossible for me as a CFO trying to be a good consumer to find out how much something's supposed to cost?
It is a hot button issue. The price transparency law that or request order that you are referencing was put in place by President Trump in his first term in 2021. President Biden expanded upon it. So it's actually a bipartisan issue. Everybody wants more. The hot button issue right now is deregulation. So the only way to get it is regulation and enforcement. They aren't enforcing it. They've put the regulation in and they are not enforcing it. It is less expensive for a hospital to not put it out, to put out their charge master, for example, and pay the fine. And nobody's coming down on them for it. Sheila, anything else?
Sure. So the only thing I was going to add to that, you may see a little change based upon price transparency. So the facility says they are complying a little bit, then in their minds a lot, but it's only a little bit, especially if it's an out-of-network claim. If you go to a hospital or a provider that is outside your network, those facilities now are saying, well, you're out of network and the charge for this is going to be $2,000. Your insurance is going to pay $500 and you're going to be responsible for $1,500. They are saying that, or most are supposed to be telling patients that before services are performed. And in their mind, that's their little bit of compliance of price transparency. They're saying it up front. That's only for on the consumer level. But when it comes to the corporate level, or for even working with paying claims, it's not quite as compliant.
Mm-hmm.
Sheila, on slide 3, you had a note that it is predicted that healthcare spending will be 19.7% of GDP by 2032. And we got a question from the members about, does that percent change under the current administration? Is that president specific data, or is that agnostic to any kind of administration?
Again, very good question. Thank you for it. So I don't know if that's, I would predict that would change under the current administration, because they are fraud, waste, and abuse conscious, which is a good thing, right? The numbers that I pulled together was not president specific, so I can't speak to that specifically. If it will change, I can say according to the way things seem right now, hopefully it will change. It needs to change.
Another question from the members. Do you pay PPO plan claims the same as EPO plan, or are they processed differently?
So the type of plan you have, we always get the plan docs for your specific claim. It's based upon your carrier contract. It's how we would review a claim for payment. Whether it be a PPO or an EPO, the claim errors will probably be pretty much the same. How we would recommend payment of removal of those ineligible charges, again, would go back to the plan doc and or the contract with your carrier. And because every contract can be different, it's hard for me to speak about that in general terms.
Or the self-insured employers that maybe they have direct contracts with hospitals or clinics or provider groups. Is there any more or less errors, any more or less access to data? Any thoughts or comments about those self-insured employers?
So self-insured employers that have direct contracts with a specific surgical group or a physician's office, most of the time the amount that's going to be paid is already established in that contract. So the errors on those claims are really null and void. So what I'm simply saying is this: if a self-insured group has a contract with the surgical group that for every total knee replacement, they're going to pay them $2,500 or even $25,000. And if that surgical group bills $40,000 or $50,000, their payment's going to always be the same based upon their contract, if that's a specific contract for that service. So our reviewing of the claims at that point would not yield any additional savings.
From the data geek side of it, the self-insured, self-administered plans have more data, but it's usually pretty disorganized and it takes some time to clean up, but they do have better access to it because they're getting it on a daily basis and they have to approve every single payment. Fully funded plans, those data sets are typically in Anthem or Cigna or United Health's data warehouses. We know their data libraries very well, so you just should be able to ask for it. You know, we want these 25 different data items or dozen data items, and we know they're in there, so they should be able to export them. It's really just asking for it, and we found that once we can get those data sets, they're pretty well organized. They should be. I hope that answers it.
Is data available that could compare within my carrier, my plan design, if I'm optimizing the cost that to alert me as an executive who's supposed to be reviewing this, that my employees are not being good consumers. They're selecting consistently the highest cost provider of the service. Because I think you mentioned it earlier, sometimes there can be like a 10x difference and where you can have a procedure done. Yes, they needed the procedure and you were charged the right thing but we're just not optimizing. We're not selecting the best place to purchase it. I guess I'm thinking like I do at 10 hours worth of research before buying a television, and 10 seconds before providing where to pick my labs.
So
sorry,
go ahead, Jonathan. No, go ahead, Johnson. I'll go after you, please.
As an employer as well, we see this, I see this all the time. And the word is panic. And if something is wrong, people panic. Their first thought is not, oh, I should really research what I'm going to pay. It's, I need to get this done as soon as possible. And we have a lot of really qualified people here, wonderful people that know the ins and outs of the healthcare system. And they know when they are on a day-to-day calm basis, I should investigate where I should get my prescription filled. But when something goes wrong, and ER visits are the number one thing, but when they need a surgery, they're not in a place pain-wise where they're going to say, I'm going to go to 4 different providers and see what they can do. However, again, from the data sets that we can get from our own clients and groups, we are able to show that information, which is why being an independent third party with this type of software is fantastic, because we are agnostic. We don't care about the plan. We don't care about who's going to get what. We care about what's the best value. So we can provide that information. And there are a lot of people in that space. That is not our core business. There are a lot of platforms out there that will allow you to analyze those things. But we can dig into it and we can show you very specifically where the cost savings could be. The problem is the education has to be up front and they have to not panic. And that is hard.
Which is exactly what I was going to say. Sometimes employees will go to their HR department or go to someone within their benefits and say, I need help. That is, having that open door policy is good. We work a lot with HR groups or benefit specialists for a specific plan because they may have someone who's just been diagnosed with renal failure and they've got to have a kidney transplant, and they may come and say, where is the best place to go in our area? Who's the best place that not only is going to be good for as a provider, but good for the plan as well? Or Beacon, can you help us negotiate the cost on this? And we do that. Again, that's not our core, but we do it often, very often, to help save on healthcare dollars as well.
And the best defense against a lack of education is a review tool. The ability to review it before you spend the money. Sorry, back to you, Robert.
To build on that, and what you had in slide 4, 94% of reviewed claims had errors. That almost seems like the business model. Like, are the errors an accident or part of the business model? If my accounting team had errors in 94% of our invoices or our payables or our journal entries, somebody's getting written up. Is this an accident? Is this by effort? Do you see with it now you have a large data set? Do you see, very interesting, lack of training, or they're just clicking buttons, charging you for whatever you pay for?
Sheila, would you like to take that one?
So I'm just going to be honest with you. I'm going to tell you that I worked for the number one trauma services centers here in Virginia. And part of my job was I followed providers from the trauma bay to the operating room. I was a conscience for them. Like, if you didn't document it, it didn't happen. You didn't do this, so you can't bill it. Eventually, I'm like, Sheila, you're a good job. You've saved us $1 million. But if we get $1 million a year, but if we get rid of you, we can make an additional $2 to $3 million a year. It has become a part of the business model for facilities to actually capitalize as much as possible on every bill. And if they get caught on 1 or 2 bills, 5 or 10 bills, even 20 bills a year, then they'll give the money back. They'll accept that they've been wrong, but look at what they've made if they don't. And unfortunately, that's where we come to. When you ask if you want me to say, is every facility or every provider egregious? I can't tell you that. But I do know there are a lot of bigger healthcare systems that being egregious is part of their business model. It's part of their profit margin anymore, unfortunately. Because really, there's not a lot of people looking over them. There are not a lot of people can look at a bill and, especially your normal consumer. Your normal consumer cannot look at their EOB and know that their employee has been overcharged. They just don't know.
And total agreement with what you said. It also goes back to what you were saying about Medicare pricing differentials in different states. Yes, it is part of the business model. It's got to eventually level out a little bit, but for now it really is. Let's see what we can get.
How do you get a refund from the hospital if you've paid something. That was in the presentation, and you said it could be hard, and it can take a while, but that sounds really hard. And like they're gonna find there's got to be 20,000 forms to fill to get money back from a hospital. Talk to me a little bit about that, the collections process.
Sheila, I'd like to jump in on this first and then hand it off to you for a detailed
Absolutely.
explanation. It can take a long time. It also, if you catch them red-handed, can take 2 weeks. The thing about refunds is everybody goes, oh my gosh, we had an $11 million claim last year. We should have them review that. $11 million. If we find $1.5 million, good luck getting $1.5 million back from a hospital's pocket. Does it happen? Once in a great while, yes. But the real refunds come back on lower dollar claims that they know they're billing improperly on. So it does take anywhere from 6 weeks to a year. We have some that go on longer than that. Sheila has a plethora of examples for stop loss claims that take a long time that we are able to recover hundreds of thousands of dollars. But most people think of, oh, I should just look at the really big claims. You should also look at the mid to small claims, because we get refunds for $50. We get refunds for 50,000 too. But it's looking at everything holistically. Go ahead, Sheila. Sorry.
Sure. Again, post-pay is it's better than doing nothing, right? So what we find normally, like, we recover about 40% of what's requested on our AR for post-pay claims. And that could be, again, anything, as Jonathan said, from $50 to $250,000. We have received $250,000 many times, but it also took our team 18 months or more, literally calling every week, going to CFOs of that facility and going through the process of proving per Medicare guidelines, per the Federal Register, these lines should not have been billed nor paid. And finally, they say, okay, we've had a hospital administrator, because it has to go through many levels when it gets to a certain dollar amount, to say, boy, I hate to write this check. It hurts me to write this check. And we know it does, but the bottom line is they know they owe the money as well, right? So refunds are hard, but we do get them. We have one of the best teams in the industry that have contacts and people that work with healthcare systems across the United States. I think success on refunds really depends upon the facility and how honest, that's a good word, they want to be. Oh, we got caught. Yep, they were right. No, we were wrong. Yes, we need to make this right. Compared to that facility that would come back and say, yeah, we're not paying it. We're just plain out are not going to pay it. And that's what lowers the percentage of refund rates.
Kind of a macro and then a micro question specific to your group, if the answer is different. Interested in, from the question from the members, how is Beacon getting compensated? Is this like a gain sharing model where it's like a commission? Is it fee-based? And is there kind of like an industry standard? Like, if we're considering these partners, what should we be looking out for? And is it normally percentage-based or just fee-based?
Great question again. So normally what we do is we share in the findings, if you will, or in the recovery. It's usually somewhere around 25% of the savings that Beacon recovers. But that's not the only mold, right? We also will consider and will do a PEPM model. We are very agnostic in that we can conform to whatever a client needs us to be. A bigger group may want caps. A bigger group may want to do a PEPM rather than a percentage of savings, whereas a smaller group may want to do a percentage of savings. The percentage of savings is good because simply, if we don't find anything, there's not a fee. If we look at 5,000 claims and 2,500 of them are good, then Beacon has performed a service for you for no fee.
And to add
please,
just
Jonathan.
another piece on that, we actually went in with a flat rate model because a lot of contracts out there, specifically from Anthem, state Anthem's allowed to review it and they'll take a percentage of billed charges, but you can't use an independent third party to do it and pay them on a percentage of billed charges. So we went in and said, well, let's do a flat rate. And we just did one, I think it was last week. We still do offer that. Ironically, I guess people were concerned that we wouldn't be motivated to look for every single dollar if we weren't doing percentage of billed charges. That's one of the big things that people get confused about here. The real value in what we do and how we get compensated is making sure that we have client relationships that go on for years and years and years. It's not about whether or not we get the quick, easy pickup in terms of a few months of revenue. For us, once you see what we are able to do, you're going to want to do this, or you're going to want to have someone do it every year. It's just having people understand that. And some people are hung up on percentage of billed charges versus flat rates. As Sheila said, we have multiple different ways that we handle it.
Have you ever found an error that was actually beneficial to the plan, to the patient? And what do you do then if they unbelievably, for some reason, undercharged us? Has that ever happened? And what do you do?
Good question. So the first question was beneficial to the plan, or do you mean to the provider or hospital? Like they haven't been paid enough?
Yeah. I mean, like, let's say me as the CFO of the company and the employee, or their dependent that went out and got care. What if you found an error, but it was because the bill was light? We got charged too little somehow. It was an error in our favor. Do you ever find that? And what do you do about it if you were to see something like that?
It does happen. It is typically a processing error on whoever the payer is. So it could be a TPA, could be the insurance carrier themselves, whoever's doing the processing. We make them aware of it, and we make the group or the company aware of it, and it is the payer's responsibility. We can't do anything at that point, but we do make them aware of it, and typically there is a second payment or third payment made.
That's right. So what you can almost guarantee for every provider or every facility, when they make a bill on their AR, they know how much they should be paid. And if their EOB comes back to them without an explanation why they weren't paid that amount, then they're going to go back for an additional fee. We find it and see it all the time. We'll make a client aware that the facility has been underpaid, but almost 99.9% of the time, the same time that we've made them aware, the TPA aware, or the administrator of the fund, the facility's done the same thing.
Hospitals act like they're barely breaking even. And I mean, I read it all the time. I think I even know some CFOs, and they're all like, oh, the world, we're barely, we're going to be on food stamps. We can't possibly pay our bills. But somebody's making some money. So who is making money in this this ecosystem?
Another very good question, Robert. So I can only give you the examples that I know from the healthcare system I came in from, right? And I don't want to make this like this is blanket what's going on across the border. The healthcare system I came from in medical surge, we had a budget every month of like $2,500 and we could buy ink pen. True story, right? Our providers could. So I'm not going to, I really want to be careful how I answer this, to be perfectly honest with you. So there may be hospital systems in the rural areas that are having a harder time financially. Let me be perfectly transparent about that, right? It depends upon, again, you're in the rural area, the people can't get there. If it's a heavily Medicaid or Medicare population, the reimbursement is less. So the expense for new equipment, the best medications, the best providers, paychecks, then that makes a big difference. So if I had to be perfectly transparent. But there are a lot of healthcare systems that have a great mix of commercial payers along with the Medicare payers and not as many Medicaid payers that are not suffering as they would want us to think. I don't think so, because I've seen some budgets and I know there are places, fraud, waste, and abuse. Can I say that one more time? Fraud, waste, and abuse that may needs to be tightened up, right? So truthfully, but also may I say this, the best story for me as a CFO or not a CFO, but a CEO, if I want my healthcare system to make more money, I tag along to the story of the healthcare systems that's in the rural area that needs more funding, that needs more help, because their lack of success can only help me if everyone's get distributed the same funding, if you will, if that makes sense.
Last question is, how do you partner with my HR team, my broker? You know, how does this all connect together? And give me the 60-second how this maybe like triangle superstar team actually works together.
Our goal is to make sure that we are helping to reduce the workload of your team overall. The typical way that we go in is to discuss with the HR team, how do we access the data? Can you please involve us in that process? Because we know the ins and outs. Most HR teams do not understand the data piece of this, and they are going to be just processing and working on employee needs. So we try to get very hands-on and very involved in the acquisition of the data process. And then once we have that in place, the HR piece of it is very, very simple. It is really, they get a report from us every month. They may send us something when there's an extravagant claim or something that's really gotten out of hand. But our goal is always to reduce the workload on them. That is what our resolutions team and Sheila and her team do best. And they are able to work through the initial apprehension of, oh my gosh, so you're telling me I have to look at every single claim? No, no, no. We look at every single claim and we give you the data from it.
And one of the easiest things to do is for the HR team to introduce us to your TPA or your administrator, whoever's paying your claims. Let us send your HR team a report every month, but let us work directly with your TPA. And that excludes the day-to-day work from the HR team. We work with the TPA who's working with your claims every single day. They'll send us a file every single day. Once at the beginning, after we get past the introduction, if you will, the courting period, once we start getting files, we send them back to them almost daily. There's very little back and forth. We may meet once a month, maybe once a quarter, things going well. But the biggest takeaway I want you to understand is we are an extension to your TPA. We are there as their partner, as a way to be there to help the client or the companies to maximize their savings on healthcare claims, which is, again, the numbers are staggering as of how high healthcare has become. We are proud of the work we do. We are passionate by the work we do, and we enjoy every partner that we have.
Oh, I love it. Proud and passionate. I love it. That was fantastic. My heart is beating stronger just at thinking about this opportunity. And a couple of closing notes. More likely than not, there is an error. There are errors, material size errors in the claim information that I'm looking at every month with the HR team. And the internal group, like that's the team, but the carriers, the hospitals, they're not on our team. They're not like us. And it's nice to know there are proactive partners like yourself out there. This was excellent. And I'm thinking, I'm going to send out this presentation and your contact information to the members. This is a great document to sit down with your HR team. They don't have this, right? HR took one finance and accounting class, barely passed, changed their major, went into human resources. They don't. So they're going to need some help, and we can help them with an awesome partner like this. And I love it. Thank you guys for coaching me up. I feel way more educated on this topic. This was really excellent. And I hope you and everyone has an awesome day. Bye, everybody.
Thank you for the opportunity. Take care.
Thank you, everyone.